Awesome. Great to be here. Thanks so much. And I don't have any props like Dr. Bowden, but I've got my cell phone to keep me on time here. So the title of my remarks is called The Urgency of Now, kind of playing off Sarah's comments earlier, Sustaining Anti-Racism in Academic Medicine. So I'm a physician, and the academic space that I will be sharing about is academic medical centers. So 8 minutes to share on these three objectives. We're gonna go great. Discuss a little bit about the history of racism in medicine. Examine how racism has an impact on the tripartite mission, as we call it, in academic medical centers, from clinical care to research to medical education. And we'll close by identifying strategies, the 5 Ds, as I like to call them, for how academic medical centers, can actually achieve and sustain anti-racism. So the first objective was on racism in clinical care. And this is a paper that was published a couple weeks ago in the New England Journal of Medicine. It highlighted the fact that X-ray exposure for individuals who were Black versus white up until the 1970s was different. So Black individuals were purported to have different skin and bones that required a higher rate of radiation for X-ray imaging compared to their white counterparts. And this was published just a couple of weeks ago, really highlighting this practice. And the reason I bring this up is that the history and legacy of race and racism, specifically in medicine, has really been throughout for centuries now. And it's not been until the last couple of years where it really has been especially emphasized. And I focus on that word especially because this is a conversation folks have been having for decades now. This is a paper published in the year 2016 that talked about racial bias of medical trainees. It was a well-known study published back almost 6 years ago or so now that showed that medical students and residents at the University of Virginia had different understanding of false beliefs comparing Black bodies to white bodies. About 20% of these individuals believed that Black nerve endings were less sensitive than white nerve endings. About 40% believed that Black blood coagulates faster than white individuals' blood. Nearly 60% of these individuals believe that Black skin is thicker than white skin. Again, these are medical students, residents, who are the future physicians of our society. And so what does that mean for how they take care of patients in the future? And what does that mean for conversations like we've been having over the last 2 years, that racism is a public health issue, and one that I'd argue that goes beyond public health, but that it's actually a medical issue, a medical crisis, a healthcare issue in our society. This is a study, another New England Journal of Medicine study published back in 1999, where researchers shared with cardiologists the pictures that you see on your screen here and asked, with the same story of substernal, so right below the chest, chest pain, would you send this patient off for a cardiac catheterization to see if they have a blockage in their heart? Individuals who look like those who received the picture of those on the top of the screen were far less likely to refer their patient for this potential life-saving procedure, especially if they received a picture of a Black woman, compared to those who received a picture on the bottom of the screen. This was like one of the first studies that really highlighted the fact that there is unconscious bias in the way we take care of patients. This goes far beyond just cardiac catheterization. We see that Black patients, for example, are less likely to receive novel heart failure treatment or novel atrial fibrillation treatment, which is a disease that I study. Less likely to receive new cancer therapy, surgical procedures, pain treatment, even be referred to hospice or end-of-life care when they're reaching that level of care. And so study after study has shown these findings. And again, focusing on this slide on Black patients, but we've seen this story play out when we're thinking about Native American individuals, Hispanic or Latinx individuals, folks from certain Asian backgrounds as well. Obviously, we've seen this story play out in COVID-19, where from access to testing, to rates of infection, rates of death, access to vaccines, and now access to some of the novel therapies that we have to treat this condition, we see that racial and ethnic minorities are less likely to have the care that they need. And so how and why does that, what does that have to do with race or racism is a conversation that we'll continue to have throughout this topic today, but that was the clinical care space. What about in research? Again, one of the really key missions of academic medical centers, where we really fund the programs that we continue to maintain day after day. This is a slide that kind of reflects that history. So just one slide that I'll share here, and again, hopefully in our other conversations we'll be able to talk more about this. But this slide really is shown here, really emphasizing the work of Harriet Washington, who really highlighted some of this work in the book Medical Apartheid, if folks have not had a chance to read this yet. But this slide emphasizes the fact that this is a history that extends far beyond the US public health syphilis study that took place outside of Macon County, Alabama, one that often people refer to and say, that's why Black patients aren't going to get involved in research, right? It highlights the fact that James Marion Sims, the quote-unquote father of gynecology, was using Black bodies to experiment on some of the gynecological procedures that he created that till today are still named after him. Highlights some studies done in the reports taken out of the Medical College of Georgia, which showed that they used cadavers digging up Black graves to actually teach students about anatomy in their medical schools down there. Talks about the Holmesburg prison. I'm from Pittsburgh, just a few hours away in this city, that actually experimented on prisoners using radiation, with similar experiments taking place a few hours away over in Cincinnati. And again, this really is a history that's so important to know, a history that we didn't learn during medical school when I started just about 13 years ago, but one that really examines and describes why there may be some understandable hesitation for why individuals may not be super excited about getting involved in that new COVID-19 drug trial. What about in medical education? Again, you have to teach these individuals how to become physicians, and what happens, how we think about racism there. I'll emphasize really the inequities in who is in the classroom in our medical schools. This is a report back from 2019 that showed really the dearth of individuals who are underrepresented in medicine, including Black, Latinx, American Indian, and Alaska Native folks, who are really underrepresented compared to the US population. And this study highlighted that fewer Black men matriculated medical school in 2014, the year after I graduated, than in 1978, the year after my dad graduated from medical school back in Nigeria. These are numbers that we have to fix. These are things that we have to address. And I think hopefully the conversation we're having today will continue to inspire us for how to be able to do so. And before I leave my formal remarks, I'll leave with just a couple of potential strategies, the 5 Ds, as I mentioned. And so desegregating healthcare in the US, the patients who are receiving their care just a couple blocks away from where we're sitting today look very different from those who were receiving their care where I practice at Mass General Hospital, less than a few miles away. And why is that the case? Very different from the patients that I saw in the Bronx, where I was also learning how to be a medical student. We know that there is significant segregation in the care that we receive, just like there's segregation all throughout our country. And this is something that we have to address, using payment policy, using actual research policy as well to address that gap. Divesting from racist practice and policy, I emphasize those 2 words because it's not just I had a racist doctor who told me that I needed to do X, Y, Z. But it's really the practices and policies that we have in place that we have to get rid of. Why is it more likely that a resident physician is more likely to be taking care of a patient from an underrepresented background compared to the attending specialist physicians? That is, in my opinion, racist policy and practice. Diversifying the medical workforce, we've already talked about how we need to address that, and that starts way before medical school, as I hope we'll emphasize today. Developing anti-racist medical curricula, again, so that these conversations are not just one-offs here, but really maintained throughout our curriculum, which I think the School of Public Health is doing an excellent job at, and our medical schools have a long way to go there. And really deepening community investment. It's the last strategy there, but that's really where this whole conversation starts. Why are we doing this work? Why do we have medical schools, schools of public health, to be able to try and change the world that we're living in? It's for the people that we take care of. It's for the communities, not just for the next big grant and paper. And I'm hoping, again, as we strive to address these 5 Ds, we can actually achieve an anti-racist academic medical center. Went a little bit above 8 minutes, but I hope we were able to achieve our objectives, and really looking forward for some more conversation. Thanks so much.